Welcome to this episode of the Dental Medical Emergencies podcast. So I'm Claire Sabala, one of the clinical skills facilitators on the team, and I'll be your host for today's episode, all about seizures. Today I'm joined by Lizzie Wright, epilepsy specialist nurse at the Leeds General Infirmary, and our simulated education lead, Tamora Shenwood, and we are going to be talking about managing seizures in the dental setting. So Lizzie and Tamora, thank you for joining me today.
Thanks for having us.
You're very welcome.
Do you want to perhaps start, Lizzie, by explaining what is a seizure?
So the technical term for a seizure is the transient occurrence of signs and or symptoms of excessive synchronous neuronal activity in the brain. So it's abnormal brain waves for whatever reason that are developing. Just because you have a seizure doesn't mean you have epilepsy.
Okay.
1 in 20 people in their lifetime will have a seizure or have something that people perceive to be a seizure.
Yeah.
However, only 1 in 103 people will actually develop epilepsy. And so epilepsy is actually people who have more than one seizure within a set period of time.
Okay.
So that's the difference, really.
Okay, so what might a typical seizure look like?
There's no such thing as a typical seizure, unfortunately. It depends on where the seizure comes from, so the type of epilepsy, whether somebody has a generalised epilepsy or a focal onset epilepsy. Those are the two main kinds. Focal basically means it starts in part of the brain, and wherever that focus is depends on what part of the brain is involved. So if it's frontal lobe, people can become shouty and their mood and behaviour can change. If it is temporal lobe, you often get the déjà vu type feeling where something is completely unfamiliar, even though you know where you are, you know you're in your own home, but your front room is suddenly unfamiliar, or a funny taste or a funny smell. If it's parietal, it's often something that's sensory, so you get a funny a feeling in your arm. So I've got one lady who has ants crawling on her skin is her type of seizure. And then occipital is when there are an abnormal burst within the occipital lobe of the brain, and often there's like a red blob or visually something changes. So it's the Alice in Wonderland, things get bigger, things get smaller.
Yeah.
Those kind of things. Lewis Carroll was believed to have epilepsy, so
Right.
that's kind of where that comes from. So those are focal onset type seizures, but you also can get lots of different generalised seizures. So a traditional seizure that people recognise as a seizure is a generalised tonic-clonic seizure, where usually there's a shout out and people, as their muscles contract through the rib cage, it forces air past the vocal cords, which have then contracted, and you get a cry out.
Okay.
And then there's usually a stiffening, and people would fall to the floor, and then there is rhythmic shaking of usually all 4 limbs if it's a generalised tonic-clonic seizure. But there are lots of different types of seizure within there. So you can have a tonic seizure where you've just got increased tone and you fall to the floor. You can have a clonic seizure where you can just have shaking of one side, rhythmic jerking, and that could be arm, leg, wherever. You can have absence seizures where you just black out and you don't know what's going on. You can have myoclonic jerks, which are little smaller jerks. They're more common kind of when somebody is tired or morning and night times. So there are lots of different kinds of seizures, and it depends on the type of seizure, where it comes from, and what the patient experiences.
Okay, so Tamora, with your experience in managing dental medical emergencies and teaching that, what do we tend to talk about and think about in that situation?
So we very much focus on the tonic-clonic seizure, and that's just because we're thinking about what is most likely to happen in a dental setting where actually intervention is needed. It would be great if a dental education could give someone an in-depth knowledge of all the different types of seizure. But actually, it's not realistic. It's not realistic for your dentist to be able to differentiate between the different types of seizure. So what we try and aim for is that they can differentiate between a focal and a general, and that they feel confident in managing a tonic-clonic seizure and those important steps thereafter.
Okay, and do you tend to, what complexities might you come across in your training? Have you noticed, is anything that people particularly struggle with in that management, or?
I think one of the key things is definitely that prior knowledge. You know, in a dental setting, you can maybe think, okay, all I need is that tick box questionnaire of do they have epilepsy, do they not? But actually, we need to take that broader approach to really understand what a patient's risk factors are, how their general health is, and also if they are known to be epileptic or have seizures. As Lizzie's already said, there's no such thing as a typical seizure, and there's certain things that we could be finding out beforehand. But at the moment, I think the skill level and the confidence level of the average dentist doesn't maybe know exactly what is important, what should I be asking, and then what do I do with that information after if my patient has a seizure. How is this going to change my management? So some of it is what information is available, because of course you may find somebody and you've got no past medical history at all. Another is, how can I actually be prepared with the information I have got? So I think that's definitely a complexity. And you can see that in people's, how it impacts their confidence with their desire to maybe treat something inappropriately. So we see a lot of midazolam use favoured in the past. We've put things in place, so we've actually removed midazolam from the LDI because it wasn't being used appropriately. But again, that in itself, whilst is an appropriate thing for a large institution like us, can create confusion when you're then going out to practice and you've all of a sudden got midazolam available. So I think there's a couple of things that make seizure management quite complex in a dental setting.
So if we just take it back to, we've got potentially somebody having a generalised tonic-clonic seizure in the dental setting, what should our ideal management look like?
So you should already know that the patient has epilepsy. So that if this is the first seizure, that's completely different. But if this patient has epilepsy and you know that they potentially could have seizures, it's useful knowing things like, are they usually prolonged seizures? Is this, a common seizure type for them? So if you should already have that information beforehand. But when a patient is, say, in the chair and having a seizure, the best you can do is lie them as flat as possible. If you can get them out of the chair without damaging themselves or yourself, then grand. But if not, leave them where they are. Don't try to put them in the recovery position. Do not try to put anything in their mouths. And if they have anything particular in their mouths, if it's secure and it's there and it's fine, that's absolutely okay. But ideally, try to take it out if you can. Mm-hmm. Don't put any fingers in the mouth, whatever. I've had fingers bitten off before now, so that's not ideal. Time the seizure. 80% of seizures stop within 5 minutes. Mm-hmm. And so the good thing about that is if you then get to 5 minutes, then you know that is a problem, and that's when an ambulance should be called, because 80% of seizures then go on to 30 minutes, and that's basically going into status epilepticus when intervention is required for somebody who has generalised tonic-clonic seizures.
Okay.
If it's a first generalised tonic-clonic seizure, one of the first things you need to do is call for help and get an ambulance.
Okay. All right. And you mentioned prolonged seizure there, so that's 5 minutes are we talking about?
Yes. So it's that cut-off, because you've got the 80% of people stop within 5 minutes. Therefore, you've got a time frame for that person to stop having their seizure and start their recovery period. And if they don't, then that's when you've got the increased risk of going into status and interventions are required. If somebody is known to have prolonged seizures, they may have a buccal midazolam protocol, and it's appropriate to use that.
Okay.
However, not everybody does, and not everybody would normally have a prolonged seizure.
Okay. So it's, except for obviously calling for an ambulance, if they've not had a seizure before, this is their first seizure, or if we get into one of those situations you mentioned, like a prolonged seizure, it sounds like the management's fairly hands-off in terms of, I think that's especially something that probably people struggle with, because you feel like you need to do something to help that person, don't you?
I'd agree with you, Claire, and I think one of the things that it almost seems to contradict all of our other messages in the Dental Medical Emergencies team is we're always saying A to E, A to E, A to E. And actually, when someone is having a tonic-clonic seizure, there is not much of the A to E that you can undertake safely or that would give you accurate information. So that's where people can start to feel really uncertain or start doing things that may place either themselves at risk or risk hurting the patient. So it is, as Lizzie said, it's grounding yourself, laying the patient flat, trying to maintain safety, 15 litres of oxygen via a non-rebreather mask if it's a tonic-clonic seizure, and then your time, and then making your decision regarding ambulance and midazolam based on everything else you know about that patient. So is it prolonged? Is it a serial seizure? So that's a seizure of any length that's occurred 3 times within an hour. The other thing that we must make absolutely clear is giving midazolam is not without risks. And if we are giving midazolam in a dental setting, so this is a setting where people aren't maintaining somebody's airway on a regular basis. It's not like doing it in A&E or other wards where, airway management is our bread and butter. We must be calling an ambulance before we administer. If we've made the decision to administer midazolam, we need to be calling an ambulance at the same time, because we just do not have the facilities to maintain someone's airway if they do have a bit of a deeper response to the midazolam than we were maybe initially expecting.
So the NICE guidelines say that midazolam should only be given for prolonged seizures, and that's really important. And if a patient is having a seizure, like you've said, put on oxygen where possible. Don't be concerned if during the seizure activity the cyanosis continues. They pink up within 10-15 seconds of the seizure termination, and then you put them in the recovery position and open the airway immediately after the seizure activity has stopped. It's then common for people to be sedated, drowsy. Some people can be combative, confused for quite a while afterwards. In some people it can be a few hours, and obviously it's not appropriate to continue with the dental intervention that they're having, and they need to be safely monitored elsewhere.
Yeah. And just returning to Lizzie's point about oxygen use and why it's so important, if we actually think about the stages of the tonic-clonic seizure, we've got your kind of your tonic bit where you're actually, that's it, you're not breathing for a short period of time, so your oxygen saturations will plummet. And then as you move into your clonic, you've got that discoordinated breathing.
So if somebody's having a first seizure, then obviously they'd be ending up with the paramedics in an ambulance at that point. If somebody has known epilepsy and they have a seizure that's normal for them, and they're in that post-ictal phase, what's the best thing we can be doing then?
It's supportive management. So usually if somebody has seizures, then they come with somebody. That's recommended. And so you would support them with that individual who knows what to expect.
They're likely to have a plan in place.
They're likely to have a plan in place. They're likely to know, well, they'll be like this for 20 minutes or so, in which case, they just need to be left where they are for 20 minutes or so. And then they can, usually, if we know that they have epilepsy, it's really difficult to say, right, we're done now, thank you very much, goodbye. But they can go home because this is their norm. I've got people who have multiple seizures per day. Sometimes every hour people are having seizures, and that is their life. And, it's really difficult sometimes to take a step back and go, actually, it's okay for somebody to go home with seizures, because that's where they were when they came in the room. Yeah. So that's where they're going to be when they go out. Just because they've had a seizure, that doesn't change.
Yeah, they don't want to live in A&E.
No. No, nobody wants to do that.
So are there any common mistakes we see in the dental setting in management of seizures?
Yeah, I think common mistakes are overhandling the patient. So sometimes we see people trying to brace heads and actually hold airways open.
And what's the risk with that?
The risk is injuring yourself, but also injuring the patient. Yeah. Lizzie's probably got a better explanation as to why holding someone's neck when they're moving, you're risking neck injury, aren't you?
Absolutely, yeah. And it's so difficult, isn't it? Because it looks so
Violent.
hideous. It's so violent and it's terrifying. But if you're trying to hold somebody who can't voluntarily control their actions, then they're basically fighting against what you're doing without realising. So you're much more likely to cause damage to the muscles. And also by doing so, if anybody's got any kind of awareness as they are coming round from a seizure and they know that they're in pain, they're much more likely to be combative and worried about things.
Right. So actually it's not just during the seizure that this creates a risk, it's actually after.
Yeah.
Interesting. Yeah. I think another area we've kind of already touched on, which is that
Misuse of midazolam.
misuse of midazolam. And I think it comes back to what you've said, Lizzie, about it just looks so scary when someone's having a seizure. Lizzie and I worked in neurosurgery for a long time together.
We did.
And we've seen a lot of seizures together. And I would still say seizure is one of the most unpleasant things to witness. It just looks so violent.
And you just want to intervene to stop it.
You want to do something to make it better.
Yes.
And I think, that's with an awful lot of healthcare experience, working in that area. I still fight that feeling of, got to make it stop.
Yeah.
Now, you can imagine as a dentist, this is something that's far more unfamiliar. I think that feeling of distress and I must do something is likely to impact on how quickly they want to turn to midazolam without actually weighing up the risk benefits. As you say, some people have seizure an hour and that's their life. Doesn't mean they take midazolam every hour. And it's thinking about that holistic view of what is normal for this patient and using that to ground your own emotional response to something that is really, really scary.
So we should just be using midazolam in a very specific situation from the sounds of it, which is for prolonged or serial seizures or if indicated by a care plan. And then we need to be calling an ambulance if it's in a dental setting because we need to have the facilities to manage that airway if there's respiratory depression.
The likelihood of that is actually quite slim if they've already had the drug. The problem being is if it's their first dose of the drug.
Yeah.
But usually, if it's second, third, fourth, fifth plus dose, it's rare that there is any kind of respiratory depression. However, it's still best practice.
Best practice.
Yeah, it's just thinking about the context and our professional responsibility that we are taking care of that patient. And although they might not always go off in an ambulance every time they take midazolam, if it's a regular occurrence for them, I think we just have to acknowledge the limitations of a dental setting and err on the side of caution, but not so much that we're interrupting someone's life.
Yeah.
So every seizure does not need an ambulance. And I think for a lot of people, that's actually a really brave step not to call an ambulance. And I think it's okay to say that.
Yeah.
I think it's important for the dental community to recognise this is really scary, but doing the right thing can be not doing anything.
Absolutely.
But that takes courage, and how you feel confident in that decision is understanding the whole patient and what is actually going on and what why we do what we do, not just doing it.
Yeah, absolutely.
Well, to give you the confidence to make those decisions if you did have a patient having a seizure, it sounds like you need to know a bit more about them other than just do they have epilepsy or not. What sort of questions might we be thinking about then, asking our patients who have epilepsy?
What I would normally ask is, how often are they having seizures and what are their seizures like? Often the patient themselves can't tell you and you have to ask a witness. The carer who's with them, the parent or guardian, because then you know what to expect. It does help to know if they do normally have rescue medication.
Okay.
Because
so that would
obviously
be such as midazolam.
Midazolam. There is also something called clobazam, which other people do use, but that's not something that we're using in this scenario.
Yeah.
But a patient can use that sometimes if stress brings on, if a certain situation brings on seizures. So ladies around their period time are more likely to have seizures, and so they can use a drug called clobazam around that time scale, usually in the run up to the period or during the period themselves. Or you can use it for people who have clusters of, for example, focal onset seizures. So if they have a littler seizure than a tonic-clonic, and they have more than 2 or 3 within a set period. Sometimes it's 30 minutes, sometimes it's an hour. They can take the clobazam and it can prevent them from going on and on and on. Because the more focal seizures you have, the more likely it is to develop into a generalised tonic-clonic seizure because the brain gets more and more irritable.
So it's almost prophylactic in its...
Sort of preventative.
It's preventative.
Yeah.
It's just to try to put a stop on that brainwave activity, calm the brain down and stop it from developing
before
further.
it escalates.
And that's something the patient would know about how to take it themselves. It's not something that we'd need to be worrying about administering to our patients.
But it would give that, knowing it, would give it that context that actually if a patient's come in and they're prescribed that, then it suggests that they have these clusters. That's something that, being forewarned is forearmed.
Yeah, definitely.
And, we can have that conversation with patients, are you having a cluster? Have you needed to take this recently?
Yeah.
And that will, again, make us maybe feel more in control if the patient does have a seizure. We maybe won't worry quite so much and we'll feel okay to step back and roll with it. However hard that is, it's really hard.
Yeah.
But sometimes it's the right thing to do.
So we'd need to think about whether or not they have epilepsy.
Yeah.
If they do have epilepsy, how often they have those seizures and what those seizures might look like.
Mm-hmm.
Any medications or rescue medications they might have.
Yep.
Is there anything else that you think you might want?
Probably the only other thing I would ask is when their last seizure was, because if we haven't done that, have we?
No, I don't think so.
So when the last seizure was, because if you know that they're going to have a cluster, when they have seizures, they have a cluster and they've had one seizure already that day, there's a higher risk of them developing another.
Right.
Okay.
That's usually quite helpful. And if you then know that, the last seizure was 3-6 months ago, then you've got a good chance of things being okay.
Okay.
So I think that's usually quite helpful.
Okay. That's really helpful.
I think another thing that's really helpful and useful for the dental profession to be mindful of is right back as to what you said at the beginning, that having a seizure doesn't necessarily mean that you have epilepsy.
Yeah.
And there are other reasons why someone may have seizure activity, such as, a provoked seizure. So having hypoglycemia or hypoxia may result in a seizure. And there's, a very sad case back, I think, in 2011. A lady, unfortunately, passed away in a dental practice in Brighton. And this was because this lady was actually having an anaphylactic reaction. So she was both hypotensive and hypoxic. And she appeared to be having some seizure activity. But unfortunately, the provoked aspect of that was missed by the team. So they treated a seizure and they didn't treat the anaphylaxis side, which meant that this patient unfortunately lost their life. And I think it's just always useful to remember, particularly when it's someone's first seizure, if they're not known to have seizures, it doesn't mean that this is epilepsy. And the first thing we should really be doing is looking for reversible causes.
Yeah.
Looking for, is this patient hypoxic? Why could that be? Well, regardless of why, get that oxygen on them. Are they hypoglycemic? Okay, what can we do to correct that? Let's get the glucogen hypo kit out and start managing that side. So a seizure can be associated with a long-term condition, but a seizure can also be as the result of acute illness.
Yeah.
And I think it's very easy to forget that seizure can be associated with acute illness from another root cause. And in those mistakes, as we've seen in the unfortunate case in the Brighton practice, sometimes do have catastrophic outcomes.
We were talking before this about syncopal seizures. So this is to do with low blood pressure. Now, I've had a syncopal episode at the dentist, hence I am terrified of the dentist. And they were very good. They promptly laid me back in the chair and put elevated my feet to stop me from passing out. If they hadn't done that, if I'd stayed upright or I'd stayed in a chair, I could very well have had something that looked like seizure activity, some abnormal movement that looked jerky. I could very well have been a little bit blue. And the reason behind that is because basically my blood supply isn't high enough to give blood to my brain, and my brain is starving of both oxygen and blood, and as a result I would be having odd, abnormal movements that do look very seizure-esque. The best thing to do, if you can, is to put somebody as flat as you can, or elevate legs to try to make sure that the blood pressure is one thing that you've easily sorted out. So if this person has never known to have epilepsy, and maybe they've gone a little bit pale, try elevating the legs and see if that helps a little bit. It's a very different movement. Well, it's not a very different movement. It's a different movement from a true generalised tonic-clonic seizure, which are quite rhythmic, whereas a syncopal episode is a little bit more...
random jerks.
Yeah, random jerks and weird movements.
Yeah.
Yeah.
But I suppose, and again, in a dental setting, they're unlikely to be afforded the luxury of having seen lots of different types of seizures to be able to recognise that difference. So you tend to go with the general view, which is jerky movements. So I can really see why when people have maybe a deep faint, that they're actually escalated, like they've had a seizure because they get those myoclonic jerks, as you say. Because a dental setting has a very different point of reference. And acknowledging that as well, I think, is a step towards safety.
Yeah.
You know, you're not going to have the same experience to reference, and that's okay. Yeah.
I guess, and the most you can do in that situation, if you are unsure and you are escalating to an ambulance, is to make sure that you document and are aware of what has happened. So maybe what did those movements look like? How long did it last?
Yeah.
How was the recovery time?
I think the recovery is really important, because often when someone has a faint, they feel a bit groggy after, but they normally return to their normal cognitive state, whatever that is, quite quickly.
Yeah.
Whereas even with patients that have a shorter postictal phase, that are known to have epilepsy or seizures, it takes longer, and there's more confusion, as you know.
Yeah.
So I think, as you say, Claire, that's really important. You might not, as a dentist or a dental practitioner, be able to say categorically this was a deep faint, this was a seizure.
Yeah.
But having that information to describe it to the 999 call handler or your paramedics, if you do decide that that's what's needed, is instrumental in them then making the right decision.
That the main way in which epilepsy is diagnosed is through witness and patient testimony. And like you were saying about the recovery period, the majority of people who have a generalised tonic-clonic seizure, their first memory is the ambulance arrived, and usually an ambulance has taken however long to get there. Whereas in somebody who's fainted, usually they've come around and in this case it would be the dentist, and their loved ones are looking over them going, "Are you all right?" And they're like, "What on earth is going on?" And they're round a lot quicker. So that's part of the history taking, and then the diagnosing of what went wrong.
Great. I just wanted to quickly ask about, we mentioned right at the start, I said, what's a typical seizure look like? There's no such thing. If somebody's having one of these, so it's not a generalised tonic-clonic seizure, perhaps it's a focal seizure, what is there anything that the dental practitioners might need to be thinking about doing in those situations? Or
so the most important thing is being calmly reassuring, which is really difficult when actually you're scared senseless yourself. But once again, it's about history taking. So if you know that they have focal aware seizures or focal unaware seizures, depending on what the kind of seizure is, then you know what to look out for. And it can be something as as a vacancy. Somebody can just not do one heck of a lot, and then they're pill rolling with their fingers, or they're making noises with the mouth, which must be quite difficult if you're doing a dental let's face it. But there will be an abnormal movement, or there will be something that they will be able to notice that will be evident from the history taking.
So it's going to depend on, again, if that person has epilepsy, knowing what might happen and what that person would like you to do if that does happen.
It would be very unusual for somebody in a dental practice to have a focal onset seizure for the first time. It would be much more likely for them to realise that it was something bigger. I don't think I've ever, in the 16 years I've been doing it, had anybody come in recognising a focal onset. Unless they've had to go to the GP. It's something that is quite difficult, and often they've gone years and not realised until they've had a big generalised tonic-clonic seizure.
Okay.
That's really common, unfortunately. And even, we've had people who've been like 40 years having seizures.
Yeah.
And actually, it's just because they had a generalised tonic-clonic seizure that we've realised that the funny smell and the funny taste they had was not just them being a bit weird on a day.
Yeah.
It was actually a seizure activity.
Yeah.
Oh.
Interesting.
There's a couple of things we haven't mentioned. So there's obviously there's lots of different kinds of epilepsy,
Yes.
but there's also other things like dissociative seizures, which dissociative seizures is not an epileptic seizure, it's more a behavioural type thing. It does often look very similar to seizures. This isn't something I'm expecting any dentist to be able to diagnose the difference between. It's just an awareness from a safety point of view. Somebody who has a dissociative seizure, they used to be called non-epileptic attacks.
Or non-epileptic psychogenic seizures.
Or psychogenic non-epileptic seizures.
Right.
But the acronym for that is penis, so I refuse to use that on principle. So I will use dissociative seizure, thank you very much, or dissociative attacks, actually, I think, because they're trying to distance
The
seizure
seizure
word
element,
from what it actually is, because it's a behavioural thing.
Yeah.
And sometimes it's as a result of stress, so obviously some people find the dentist quite stressful, and so you may be more likely to have those. So even somebody who has a non-epileptic attack would still be at risk of developing an attack whilst in the dental chair, or in the dental environment. But the treatment would not necessarily be the same.
Okay.
So long as you were confident about that. And I think the chances of that happening and somebody being confident that this is a non-epileptic attack is really slim.
Low,
so even if somebody says, I have non-epileptic attacks, I have dissociative seizures, or the FND, functional neurological disorder, which can manifest in lots of ways if they say FND, the care and the practice would still be the same to maintain the safety of that individual. And if you are worried, call an ambulance. Because we're not expecting you to differentiate. We're just expecting you to hopefully keep that patient safe. Perfect.
Yeah.
Very good.
All right. Well, thank you very much, both of you. And hopefully everyone's enjoyed listening. And we'll see you in the next one.
Thank you very much.